nine times out of 10, when I have clients who've got hormone issues, especially younger women, there is just no test for progesterone. And I know that my issue was, well, I was not diagnosed for 12 years after battering on doors repeatedly and with my premature ovarian insufficiency. My progesterone was never tested in hormone panels, never, ever, ever tested. And had it actually been tested, it would have been shown to be really low. It would have shown to, maybe flag up a problem. It would have, but it just wasn't tested until at the very end of my tether. I went to see an endocrinologist because someone had said, it sounds like you've got Sheehan syndrome. And he was like, well, if you have, that's so rare, that would be very exciting because I don't ever see
God.
it. Yes, he went, this would be a career first. And when I went back, he went, no, I'm sorry, it's common garden menopause. I was like, oh, and actually it's not, it's POI, and that's a whole different kettle of fish. Um, and so I struggle then when you sort of say, testing, but earlier in life. And for me, I have this utopian vision of what I see women's hormone health could look like if we had an opportunity to completely disrupt the system and start again. It would almost be like there is an age where, a means test is done on where someone's hormone balance is. So the difficulty we've got now is that we've got a hormone dysregulation epidemic. So even younger women have got hormones that are all over the place, but that there was almost like a stake in the ground after puberty at some point, which is, okay, this is where someone's progesterone is. And then almost being able to mark it at different times in their life to say, well, this is where they are, and this is where their hormones are at, and all the other hormones that go along with it. And I kind of feel that it shouldn't actually be that hard to be able to check that's where someone is, so that when we come into midlife, you're almost able to see these markers and where their indicators are for cancer. But that's not where the medical system works right now. It's not where any system works. So I'm just really interested from your perspective. I'm going to come into progesterone in a minute, but from your perspective, if we had an ideal way of working with women's hormones, so we'd stopped missing all of these things and it stopped taking people 12 years to get diagnosis, do you have a sense of what that could look like? I'm curious. That's just a curiosity.
Yeah,
I'm
well,
throwing that question at you.
what I would say first of all is I'm not sure it's very useful divorcing tests from the lens with which you are interpreting the test. Right. The problem is people seem to think tests are the gold standard. You're going to do a test, you're going
Mm,
to be told everything you need to know about your body, and actually it's just not true.
mm,
It's complex. So the one of the things about the mainstream system is, they're not individualizing. It's not really personalized medicine yet. It's as we say, it's been based on a model of diagnosis and drug for that diagnosis. So, you're in menopause, here's the treatment for menopause. So it's not really been looking at the journey, the spectrum, the dysfunctions and imbalances that lead up to disease. So that's why, even if you go to your doctor and you fight against the guidelines to try to get a test
mm,
for your progesterone levels, and then they do it, but they don't have the lens or the toolkit to address that, right? They're not going to tell you about supplements, they're not going to tell you about your diet, they don't
mm,
have the lens to do all of that. Um, what good is it? And in fact, it might even end up being counterproductive where you fight to get the test and then you're told we did the test and they're normal. Right. What
mm,
they mean is, from our lens, from where we're standing, you are not yet in menopause, therefore you are normal. So then the patient goes away thinking that they've had all the tests done and that there's something else going on. They're going mad or whatever. They've got something worse, or they go on their own spiral. So I'm really trying to move away from the idea of tests without the right lens of interpreting the test. A test is only worth its interpretation. Is the bottom line. And I
mm.
think, in this very logical science-based world, we are inclined to think that a test is going to give us everything we need to know.
Yeah.
I would look for patterns, right? So I think tests can be very useful. If you see the FSH creeping up, actually that's probably going to give you a really good idea about many things. It may give you a clue about, even help you make fertility decisions. It may help you with many things. It may help you be motivated to clean up your diet and change your life, and then you watch that FSH come back down, which I've seen happen so many times.
Mm.
So it can be, um, the tests are useful, but they have to be they have to be interpreted correctly. That's what I would say, rather than this idea of, here's a gold standard benchmark and where am I compared to the benchmark and I can do it all myself, because I just don't think that that really works. And I think we should
Yes.
be looking more, trying to join up, what's going on in the body, more systemic thinking as well. So that's why I say, it's relevant. For the reason why progesterone deficiency is relevant is because, yes, it can predispose to these other things. You could start to enter a state of more inflammation. So if someone comes in with lots of inflammatory symptoms and they're having all of these other host of symptoms, and then you test their progesterone, you find it's low and you treat it, that could be a real win.
I love that. I love that. My synapses are firing in all sorts of different directions. This is very brilliant. And I love it. I can't remember what my question was, but I love it.
Yeah.
So I get really cross though, and so I want to dive in a little bit more about this weird medical blind spot around progesterone,
Yeah.
because it just seems to be huge. So there's a couple of points that I want to cover in this. And I mean, firstly, there is almost a dismissal around progesterone. And when I've looked into it, I know there's wonderful researchers like Lara Briden. You know
Yeah.
Lara Briden? Yeah, yeah. I
Yeah,
mean,
I
she's
love
just doing
Laura
great
Brand.
stuff. And where she talks about the history of how estrogen was discovered, and it felt so simple, didn't it? Testosterone for
Yeah.
men, estrogen for women.
Yeah.
That's brilliant. We figured it all out. And then, oh no, testosterone's in women as well. That's pesky. And oh no, now we've discovered this other thing called progesterone, but we'll just sideline those. And then it was expensive, it was difficult to make, and so it's just always kind of been shoved in the background. But, we both know how vitally important it is from the perspective of mood, anxiety, sleep, anti-inflammation, all of these things. But there is this medical blind spot around it, and just a complete lack of testing, because it's a bit tricky to test because it surges at a certain point in the month and all those kind of things. But I think it's almost strange, this dismissal, and then this belief that the progestins are in any way connected to fixing a progesterone deficiency, which we also have so much research
Yeah.
to suppose it's not. I'm curious on your views.
This is a very important topic. So one of the things I didn't really, this links back to actually what I was saying in the last one, but I mean, at the moment, there is no licensed progesterone only treatment for
Mm,
progesterone deficiency in young women, for example, right? That's not in the guidelines. There's not a licensed product. So really, in a way, the doctor's hands are really tied,
mm,
because it's not there. It can take a lot of time. It's very expensive. It takes a lot of research to get something licensed, so it has to be licensed for a specific condition at a specific dose, basically. So we're talking about, estradiol 1 milligram for menopause. That we can get that license after many years and a huge amount of spending, and the pharmaceutical company can get that license, and then their products are made. Um, and we just don't have that, currently, that perspective of hormones on a spectrum, of this idea that hormones decline, and that even in the declining stage that can cause symptoms that are worthy and important enough to treat. That lens has been
mm.
missing. So we don't have the randomized controlled trials, and we don't have the product to say, actually, if someone's having irregular periods and they're really really low in progesterone, and actually it's going to stop their endometrium becoming thick, so this is super important that they get some progesterone now so that they don't end up with endometrial hyperplasia. Kind of amazingly, it's not really, we're not really seeing that. We're not really seeing, I mean, certainly for endometrial hyperplasia, we would have treatments, but we're not really seeing this general idea of treating someone's low progesterones for their well-being. We're not seeing that.
Mm.
Then secondly, still in the guidelines, although there is an acknowledgement, there is a statement in the BMS guidelines that bioidentical progesterone is preferred to synthetic progestins.
Hmm.
There's actually a much longer statement about the huge metabolic differences, the fact that bioidentical progesterone doesn't have the same negative impact on the cardiovascular system and on the vessels in terms of stroke risk, in terms of clot risk. Still, the guidelines for menopause prescribing don't say that you can't prescribe a synthetic progestin.
Mm.
There are loads of those available, right? They're sitting there on the shelves. Those drugs are still sitting there, and the guidelines aren't saying that you can't prescribe them. They're saying at most, bioidentical progesterone is preferred. even though there's loads of evidence as to why it's preferred. So that's another confusing thing for the doctors. So I think it's not very support. The system is really yeah, it's kind of weighted away from this idea of treating the dysfunctions and imbalances, treating it in a personalized way, and only opting for the best type of hormone replacement. At the moment, that's still not a fixed
Yeah.
thing. And right now, I would say that what we must be aware with patients is to kind of not give them false hope, right? Because I think if it's nice that patients advocate for themselves, of course they should. But if they go to their GP and they think that by advocating for getting a test, they're going to get the right treatment, I'm not sure it works that way. Because if the lens is still the case that we don't recognize or have a licensed treatment for low progesterone on its own, we don't only prescribe bioidentical progesterone, we also prescribe synthetic progestins. If that's the lens, then even if you
Mm.
get the test, it's not going to help in the way that actually, if you go down the functional medicine route, it is going to help. So I think we as practitioners need to be helping people understand that, because I think it's very confusing and it's actually kind of misleading if they think they can get this from, they can get functional medicine on the NHS, because I think you and I know now they can't. What we do
Yeah,
is different.
it is different. And then because the NHS option, and we're going to come on to at the end, our last topic is why the bioidenticals that you work with are so important. But a little teaser into that is, I know for me, because of this history of gut issues, possible at the time, SIBO, probable, because it came about a few years later, all of those things, the option for the body identical progesterone, utrogestan, I wasn't absorbing it. At the time, it had peanut in, which I'm fairly intolerant to, and soy and all these things. My body just didn't like it. It just didn't work. So then, like you say about the false hope, women are then going, oh, good, I'm going to just take my utrogestan and put because I've had my Dutch test and it says I've got high estrogen and low progesterone, so I'm just going to get my prescription and put my estrogen into the drawer for about 6 months and then do a blood spot test. This is kind of the way that women are trying to figure it out for themselves, but then they have a situation that progesterone isn't the magic pill that they were hoping it's going to be, because there are other systemic issues in this hormone dysregulation syndrome, as I just believe you and I are now patenting it.
Yeah.
We've now invented this thing, because there's so many other things that need to be addressed. And as you say, the doctor is never going to be looking at it through that lens. It's just, there's the medication, and then women feel really, really lost.
Yeah, I think the mainstream is brilliant, and I think it's you just have to accept, we just have to be aware of what it does and doesn't do, and I think that
Mm.
just being aware that it comes with that lens of diagnosis and treatment for diagnosis, and it doesn't generally cover in the depth that a lot of people would like, and certainly what we would like from functional medicine. It does not cover the dysfunctions and imbalances that precede disease. It doesn't cover preventative and basically wellness and functional medicine in the depth that we would like to see, and that can have really meaningful consequences for people's lives. So I think that's really important for patients to understand. I think you're right. It's fantastic if someone's gone and they've gone to the NHS, they've been given bioidentical, standardized, licensed bioidentical hormones like utrogestan. Great. But you're right. Even then, it can be more complicated, right? Because it doesn't suit everybody. And then what happens? Well, it's good for people to know that there are more routes, because at that point,
Yes.
their NHS doctor may throw up their hands in the air and say, "Look, I don't know what else to do. I mean, I've got a synthetic progestin that you can try, but otherwise, this is all I have in my book. What do you expect me to do?" So that's and quite understandably, the patient might think, "Well, I don't want to take a synthetic progestin, but I'm not getting on with this, but I can't be left without treatment. So where do I go from here?" And that's where I feel that that our approach can add another level of depth, right? Because we can actually see what people don't tolerate,
Yeah.
and take an individualized, personalized approach to treating people. Yeah, so that's kind of how I would advise it. It's been like navigating the system, isn't it, Claire? Like we have to kind of help people navigate what is possible and then say, actually, look, this part realistically, I think you should, look at the functional medicine route.